Hello, friends, and welcome back to Dr. A. Sajid. Today, we're doing evidence based medicine, and the topic for choice today is eczema. We're looking back into a study that was done in 2016 that divided two groups of people: one, young patients with eczema, and two, the carers of patients with eczema. And they followed them through to see what was the biggest factor that helped improve eczema. And at the end of the day, it turned out it was behavioral therapy and good counseling. When I was working in a general practice setting in about 7 months ago, there was a patient that I saw. And if you worked in the NHS, if you want a private referral to a dermatologist, the GP has to give out some documents. She booked an appointment with me because she wanted those documents. And whilst I was happy for her to have those documents, I sat back and thought to myself, how much, because she really hadn't used much of the creams, to be honest. She'd only had used hydrocortisone and an emollient. And I was thinking to myself, there's so many treatment options that we can go forwards with. And I just pitched in the idea with the patient herself if I could get the documents she wanted started and we could give a treatment shot on ourselves as well. And that's when I learned four aspects in eczema that I tend to apply in my consultations every now and then because I feel they cover every aspect. Number one is the use of emollients and steroids. Whilst everybody talks about how they need to be used and when they need to be used, it's more important to tell the patient the importance of emollients as compared to steroids. When people who've got eczema from a very young age, they start noticing that the steroid itself is that magic cream that if you use once, the lesion grows away and then you're good for a little while. Whilst this is the common perspective from the public, I use this opportunity in consultations to explain to the patient that eczema is dry skin, and if we can use the emollients regularly, we wouldn't have to use steroids frequently, and that if we start using steroids once, we'd want to put them away for at least 4 to 6 weeks till we start using them again. And you'd be surprised the number of times you'll figure out that patients actually don't know this and they feel they use steroids like emollient creams without really realizing that it's for flare-ups and not for the maintenance of therapy. So it's very important to talk to them about using steroids only in a flare-up, and that to lock it in a cupboard for 4 to 6 weeks after they've used it, to be brought out again to be used again. The second part of point number one would be the use of emollients. In the UK, we tend to prescribe hydromol as a soap substitute. The reason being that the emollient itself has a lard-like consistency and it's very hard to be put on clothes, and if you were to put it on clothes, it tends to stick with it. Hydromol comes as a soap substitute and it's very easy to use in the shower, to apply it about 10 minutes, and that provides the general moisturization of the skin. Whilst in general practice, I was realizing that communicating the importance of emollients and the use of steroids only on flare-ups, I felt a lot of improvement was noted on my follow-ups of eczema 4 weeks later. The second part to be talked about are the triggers of eczema. And at this point it would be good to just throw that question on to the patient, because it's hard as a doctor to know what might have triggered it, given the amount of environmental changes that happen every day. And the conversation goes something like this. So eczema tends to flare up due to certain situations. It's hard as a doctor to put my finger down, but I think you'd be best able to decide what might have triggered it. Some of the common triggers are mold. About 20% of them are dietary changes. Some people tend to react to the change of detergent. Some people tend to react to the change of hand washes. And all of these tend to trigger eczema. And whilst we would be targeting eczema, if we don't pull out the trigger, it would still be persistently there. The third part of the conversation is around the biopsychosocial. Any patient that comes into your consultation room would have a reason to come in. If they've had eczema for 26 years, there has to be something that brought them in. It could be a partner who commented on it. It could be a brother, the mother, who might have said that this needs looking into. And when you pick up the biopsychosocial aspect, how is the lesion affecting your patient? And how is that lesion impacting your patient's personal life? That's when you provide support along those lines and you push them to work towards the right direction so that those aspects can be sorted. The last part about in consultation of eczema is the itch intensity. And some people find it hard to sleep at night because the itching is so intense. I think it's fair to give an antihistamine at night for 5 to 7 days if the itching is very, very intense. And if there are signs of infection, to look into the use of antibiotics. But using these four aspects, I think any consultation with eczema becomes very, very fruitful, and it helps us cover every point on the patient's end. If you'd like to see more videos, please don't forget to like, comment, and subscribe to my YouTube channel. It helps me build up more content. See you guys. Bye.